the relevant proximal humerus anatomy, you all know that there is a head of humerus, then this is the anatomical neck, this is the anatomical neck, this is the surgical neck, this is the lesser tuberosity, and this is the greater tuberosity. These are several important various parts of the proximal humerus. It forms a ball and socket joint with the glenoid, and that we call as a glenohumeral joint. So that is a typical glenohumeral joint, which is a ball and socket type of a synovial joint. So coming to the relevant anatomy of the proximal humerus. Why you need to know the proximal anatomy? Because when the muscles are attached onto these tuberosities, that is lesser tuberosity, greater tuberosity, when the fractures happen, it tends to pull the fragment away, and that's why you need to know. So if you look at the lesser tuberosity, which is here, it is the subscapularis which is attached. So if there is a lesser tuberosity fracture, it will have a tendency to migrate medially. Adjacent to the lesser tuberosity is the bicipital groove, through which the long head of the biceps tendons runs like this, then it goes inside and gets attached onto the top of the glenoid, onto the labrum or to the tubercle. So the long head of the biceps tendons runs into the groove and attached to the supraglenoid tubercle. It is not attached here, it only runs through this place. Alright. Here there is also a small artery which runs along with this. We call it as the ascending branch of the anterior circumflex humeral, which is responsible for supplying the part of the head of the humerus. Then comes the greater tuberosity, on which supraspinatus, infraspinatus and teres minor is attached from front to back. So if you see here, this is where the supra will be attached, infra and teres minor will be attached. Upper shaft humerus, that is this part, you got the three important muscles which are attached, that is pectoralis major, latissimus dorsi and teres major. I am sure you remember the mnemonic where they said the latissimus dorsi is between the two majors, that is the teres major and the pec major. When the fracture happens at the surgical neck, because these muscles they come from the medial side, it can medialize the shaft of the humerus. Now, it is not important for you to understand how the fracture fragments will be displaced, but it is important at least at this juncture that you know that on lesser tuberosity there is a subscapularis. Through the bicipital groove is the long head of the biceps. It is not attached, it only runs through and goes inside and gets attached onto the supraglenoid tubercle. Behind you have got the three muscles, that is supra, infra and the teres minor. They are attached onto the greater tuberosity, and their predominant function is the abduction and external rotation of the shoulder. Further going ahead with the anatomy, if you look at the, like the clavicle, the proximal humerus is very closely related to the brachial plexus, very closely. The axillary nerve is very closely related to the neck of the humerus. So whenever there is a dislocation of the proximal humerus along with the fracture, this can compress upon the brachial plexus as well as the vessel, causing the transient or a complete paralysis of the brachial plexus. But more often it is the axillary nerve which is affected because it is related to the neck. Anterior and posterior circumflex means something which surrounds. Anterior and posterior circumflex vessels supply the most of the part of the head and the tuberosity part of the humerus. Again, before we move on to the fractures, we must know the normal radiographic anatomy if you have to interpret the X-ray. So these are the various things which is also discussed in the clavicle. Again, we are discussing here. This is the humeral head. This is the anatomical neck. This is the surgical neck. So that becomes surgical neck. This is the anatomical neck. And then you have got the acromion clavicle. This is the coracoid process, which is just under the clavicle. This is where your coracoclavicular ligaments would be. This is the glenoid, there is the scapula, this is the sternoclavicular joint, and this is the first rib. This is the lateral border of the scapula. This is the medial border of the scapula. This one is the lesser tuberosity. This is the greater tuberosity. So this is GT. We in short call it as GT, LT, but don't get confused. Sometimes GT could be greater trochanter or LT could be lesser trochanter. It depends which reference you are talking. It's the same thing written in the format. How does it get injured? Now, this is one fracture which can get injured because of the fall on the outstretched hand. And when it happens, usually it is a very minimal trauma. It happens in the elderly osteoporotic women. So if you are seeing a elderly person who is like 55, 60, 65, 70 who gets this fracture, it is usually because of osteoporosis. Whereas if you see the same fracture in a 35, 40, 25, 30-year-old younger population, then it is usually because of the high velocity injuries or let's say the road traffic accidents. So that has to be remembered. Elderly, this fracture is common, and that could be because of underlying osteoporosis. Again, just enumerating these Fuchs fractures. Fractures of the scaphoid, distal radius, forearm fractures, radial head, supracondylar, the neck of the humerus, proximal humerus, the clavicle fractures. What are the clinical features? Sometimes in younger patients where the velocity of the injury is very high, you may find this lot of ecchymosis. Here you can see a lot of ecchymosis. But by and large, there will be pain and swelling over the shoulder. You may find this ecchymosis and the patient will find unable to move his shoulder. These are the typical symptoms. The signs, when you palpate here, there will be tenderness over the proximal humerus. Again, since this part is very close to the brachial plexus and the axillary artery, one must palpate the vessels, one must check the integrity of the brachial plexus.